Let's look at an interesting case that is rare and can be challenging to diagnose. This is an excision of a superficial mass from a 19-year-old female patient. We can see at low power that the mass is well circumscribed with a fibrous capsule. There are lymphoid aggregates at the periphery of the mass. The tumor cells are bland spindle cells. We can see that these spindle cells form short intersecting fascicles. There are scattered lymphocytes in the background. Mitosis is minimal, and there is no necrosis. At higher power, the tumor cell's nuclei are bland with pointed ends, and some are twisted. We can see lymphocytes and mast cells in the background. Some peculiar collagen fibers are present. The collagen fibers has a dense eosinophilic center and a lighter periphery. Some people call this fibers amyanthoid fibers. Tumor cells show vague palisading surrounding these collagen fibers. This is a characteristic feature of this neoplasm. If we remember this feature, we will nail the diagnosis immediately. Immunohistochemical studies show that the tumor cells are positive for Desmin and focally positive for SMA. Other spindle cell markers, including CD34, S100, SOX10, and STAT6, are all negative. So what's the diagnosis? It is palisaded myofibroblastoma of lymph node. It has several names, including intranodal myofibroblastoma and hemorrhagic spindle cell tumor with amyanthoid fibers. It is a rare benign tumor. It occurs to patients over a wide age range, and most often occurs in the inguinal region, but other sites have also been reported. Histologic features include well-circumscribed bland spindle cell neoplasm with compressed lymph node at the periphery. The tumor cells form short intersection fascicles with smooth muscle differentiation. It is variably positive for Desmin and SMA. CD34 is negative, which is different from other forms of myofibroblastomas. This is another case. We can see a well-circumscribed mass with lymph node tissue at the periphery. The tumor cells are bland spindle cells forming short fascicles. This case has the hemorrhagic feature, which is another common finding. That's why it has the name hemorrhagic spindle cell tumor. This type of intranodal myofibroblastoma is distinct from myofibroblastomas that occur in other anatomical locations. The more common form, known as extramammary myofibroblastoma, typically arises outside the lymph nodes and is characteristically CD34 positive. Let us now turn our attention to the more common form of myofibroblastoma. Myofibroblastoma is a benign neoplasm that occurs in breast as well as many extramammary sites. This tumor often has fat component. The tumor cells are bland spindle cells forming short intersecting fascicles, just like the intranodal myofibroblastoma. Immunohistochemically, myofibroblastoma is positive for Desmin, CD34, and often positive for SMA. Hormone receptors, including ER, PR, and AR, are also positive. However, myofibroblastoma can have different histologic variants, and some variants can be difficult to diagnose. Let's look at some of these variants. This is the classic variant, with adipose component and bland spindle cells. This picture shows a cellular variant with less stroma and no adipose component. This picture shows the collagenized and fibrous variant. We see abundant stroma and scant tumor cells. Some variants can closely mimic neoplasms of neural origin. For example, as seen here, certain tumors have hyalinized vessels and tumor cells arranged in verrucae body-like patterns. At first glance, you might suspect a schwannoma, but all neural markers, such as S100 and SOX10, are negative. This can be confusing, making you question whether the immunostains worked properly. Therefore, whenever you suspect a neural tumor, but the neural markers are negative, consider the possibility of myofibroblastoma. There is also the epithelial variant of myofibroblastoma. This one can be a diagnostic trap, especially if the tumor occurs in the breast. We see these haphazardly arranged bland epithelial cells, some with plasmacytoid morphology. It is easy to confuse these cells as lobular carcinoma of the breast. Myofibroblastoma is positive for estrogen and progesterone receptors, similar to lobular carcinoma of the breast, which adds to the confusion. Myofibroblastoma is positive for CD34 and negative for cytokeratin. These immunostains help distinguish myofibroblastoma from lobular carcinoma, which is positive for cytokeratin and negative for CD34. This is another striking case of epithelioid myofibroblastoma, which was misdiagnosed as metaplastic carcinoma of the breast, a high-grade breast cancer. At low power, we can see epithelioid cells with nuclear atypia and myxoid stroma. At high power, we see single as well as small clusters of epithelioid tumor cells, as well as some spindle cells. It is easy to confuse this tumor as malignant breast carcinoma. One clue for the correct diagnosis is the background mast cells, which is a common finding in myofibroblastoma. But mast cells are not unique for myofibroblastoma, and we can see these in carcinomas. Perhaps the only way to stay away from mistake is be diligent, always asking, what else can it be? And do stains to confirm the diagnosis if the morphology is not typical for the diagnosis. This is the resection of the myofibroblastoma that was mistakenly diagnosed as metaplastic breast carcinoma. We can see that it is well circumscribed and non-infiltrative. It is a benign tumor. High power, we see these identical epithelioid tumor cells, as in the biopsy specimen. Myofibroblastomas are positive for CD34 and desmin in about 90% of cases, and about 1/3 cases are positive for SMA. Genetically, these tumors show deletion of RB1 gene on chromosome 13, and loss of RB1 expression by immunohistochemistry is seen in about 90% of cases. Loss of RB1 gene is also seen in spindle cell/pleomorphic lipoma and cellular angiofibroma. Together with myofibroblastoma, these three entities share morphologic, immunohistochemical, and genetic similarities, suggesting that these belong to the same tumor category. Finally, to summarize, today we discussed myofibroblastoma. It is a benign soft tissue neoplasm, occurs in a wide anatomic sites, with a wide patient age range. Loss of RB1 gene is characteristic of this neoplasm. However, only 90% of cases show loss of nuclear RB1 stain by immunohistochemistry. These tumors are positive for desmin, SMA, and CD34. Myofibroblastoma have many histologic variants. Some variants can be difficult to diagnose. The epithelial variant can be a diagnostic trap in breast pathology. In addition, the intranodal palisading myofibroblastoma is a rare variant of myofibroblastoma and is negative for CD34. It is great to share this interesting tumor entity with you. As you can see that many of these pictures are shared by great pathologists Dr. Collins, Dr. Chen, Dr. Jacob, and Dr. Semino at CAP and USCAP conferences. Their names are showed on these slides from their lectures. Many thanks to them.